Hello, everyone. Welcome to the Harvard Humanitarian Initiatives seminar series. My name is Fang Pham. I'm an associate professor at uh, HMS and HSPH. Today, I will introduce you to our speaker. Today, we're going to discuss about the Oropuche virus, and it's an emerging threats in Americas. And I have a pleasure of introducing you to HHI Director of Infectious Disease and Humanitarian Emergency, Dr. Eric Nilles. He's also a faculty member at the Harvard Medical School and an attending physician at the Brigham and Women's Hospital Department of Emergency. He has over 80 years of experience working with MSF and WHO in humanitarian crisis and public health emergency across more than 30 countries. Dr. Nilles brings extensive experience and expertise in addressing health challenges in conflict zone. Um, so with great pleasures, I'd like you to hand over the microphone over to Dr. Nilles.
All right. Well, thanks very much, Dr. Pham, for the kind introduction. But only 8 years with MSF and WHO. I think maybe it was mentioned 80. I haven't quite
Oh,
got there.
so sorry. Reading too many numbers. Sorry about that.
Just that's completely fine. But anyway, it's a real pleasure to talk about this today, and thanks very much for making the time on what is actually a lovely autumn day. So I'm going to talk about Oropuche virus. Some people call it Oropuche virus, which many of you will not have heard of, but actually it's actually a really interesting pathogen. And based upon what has happened over the past year or so, really appears as though this is, as Fong mentioned, an emerging threat to the Americas. So briefly, the outline. So I'll talk about the virology of the virus, epidemiology and transmission, clinical features, and then explore some of the reasons for the emergence now. So Oropuche virus has been around a long time. So why all of a sudden now is this sort of an emergency that PAHO and others are announcing alerts on? So in that sort of vein, here's a couple of the alerts that have been released by the regional health authorities. So PAHO, WHO released an epidemiological alert about Oropuche virus initially in February, and then they increased that to a high-level epidemiological alert in August of this year. There's some details included in the slide, but really the key point is that that this is the sort of a high-level alert for PAHO, and represents the concern that they have about this pathogen. And similar communications from the US CDC about the concerns about the broader threat and spread of this virus, particularly in the Americas, including in the United States. So about the virus, so this is a Peribunia viridae family virus, an arbovirus. It was first isolated in Trinidad, actually, in the Caribbean in 1955, from a forest worker in a village, Vega de Oropuche, which is, as I think you can probably figure out, is where the name for the virus came from. Since that time, there have been a number of outbreaks, mostly in Central America, mostly in South America, some in Central America, in tropical and subtropical regions. Some of these outbreaks have been pretty explosive, with up to 30% of the population impacted, so with attack rates of up to 30% in some of these outbreaks. But really, overall, this pathogen attracted, minimal global attention until the past year or so. There are no vaccines or antiviral therapies for this, largely because it's considered sort of a neglected pathogen without a lot of interest, a lot of focus, very little impact in the United States or high income countries, which is probably a large part of the reason why there hasn't been more development of vaccines and some of these other therapies. So, what exactly has been happening? So in late 2023, there were a number of outbreaks in areas that were previously known to be endemic. But in addition to that, there has been emergence into new areas, so areas that this pathogen has never been identified before. Up through September of 2024, so from January to September 2024, there's about 10,000 cases confirmed. 2 deaths reported from Bolivia, Brazil, Colombia, Peru, Cuba, and the Dominican Republic. So of all of these countries from South America, so Bolivia, Brazil, Colombia, Peru, there has been expansion in the range of this pathogen outside of the previously identified endemic areas. And then the first detection of this virus ever was identified in Cuba and in the Dominican Republic. There have been about 75 travel-associated cases in the US. So this basically is when somebody has been visiting one of these countries where there is ongoing transmission. They return to the United States with undifferentiated fever. It's unclear what the pathogen is, and so there's sort of a broad investigation, particularly if the samples are sent to the US CDC, and they investigate those samples, test them for a whole range of pathogens, and they have identified through this process, this is sort of a standard process, not just for Oropuche, but they've identified about 75 cases or so that were imported into the US during 2024. And similarly, cases identified in Europe. A large number of these cases were both those cases identified in the US and in Europe actually came from Cuba and were identified in Florida. So had been traveling in Cuba, came back to Florida, and then the diagnosis, the pathogen identification was made. So you see the map here on the right side. So these are the areas of transmission during 2024. We see the inset box of the Caribbean with Cuba and the island of Hispaniola, or the eastern side of Hispaniola, as I'm sure most of you are aware, is Dominican Republic. I do a lot of the research, the CDC-funded research that I do has been done in the Dominican Republic, actually. So to know the country fairly well. It's sort of interesting because these cases were actually identified in the Dominican Republic through a process of retesting samples that had been tested previously for dengue. They were dengue negative, and they still had those samples in storage. So they tested the samples, and about 35, 37 of them tested positive for Oropuche virus. A lot of details about how many samples were tested, etc., and the geographic range of the samples is sort of unclear, but certainly these cases are identified and represent the first known transmission in the Dominican Republic. Almost certainly, both in Cuba and definitely in the Dominican Republic, there's substantially more transmission and almost certainly a larger geographic range than is represented here. But surveillance for this pathogen is really limited, just because it's not a typical viral disease that is being tested for. So it's only under sort of special circumstances, and because of the outbreaks in South America that there was even this testing was performed. Okay, so onto the transmission. So the primary vector for this pathogen, or what is thought to be the primary vector, are midges, Culicoides paraensis, But in addition to that, there's a number of mosquito vectors that are thought to play a role in transmission. Um, the issue is that there just has not really been that much research on the ecology of this pathogen. So understanding the vectors and their respective roles is really poorly characterized. But certainly at this time, it's thought that the Culicoides pariensis, the midges, are the primary vector of transmission. And then the host, so this is a zoonotic infection, so originates in primarily mammal hosts, sloths and marsupials. Um, it's thought that birds and rodents also may be involved in the transmission and may act as hosts, but again, somewhat poorly characterized. Humans are accidental hosts in the urban settings, and almost certainly there are additional hosts that have not been identified. So on the right, we have this figure, cartoon figure, and it represents sort of the wild or sylvatic cycle over here on the left. And then we have the urban cycle, and this is typically the cycle that causes these explosive outbreaks. And again, driven primarily by the midge Culicoides, but in addition, the very widespread mosquito Culex quincifasciatus is thought to be involved in the transmission. This is important because when we think about control measures, we need to understand how the pathogen is being transmitted to the humans. If we want to implement effective control measures, we need to know what those vectors are, and then direct control measures to them. So the fact we don't really have a good idea of the transmission cycle sort of limits our ability to do that. Although work now is increased work is now being focused on this, given the increased attention to this pathogen. Okay, so vertical transmission. As I mentioned previously, this is essentially an undifferentiated, self-limiting febrile infection, not high rates of mortality, but one of the concerning features is this vertical transmission that has been identified. So vertical transmission, just to clarify, is when the pathogen is transmitted from the mother to either the fetus or the newborn. So that can be in utero through the placenta, and the virus is transmitted to the fetus while the mother is pregnant. It can be during childbirth and exposure to blood and amniotic fluids, other fluids that contain the virus, or it can be through breastfeeding. In general, that's the sort of the definition of vertical transmission. The first case of vertical transmission was for Oropuche virus was actually just identified in June of this year. So this is all sort of relatively recent information. RNA from the virus was detected in a stillborn infant in a woman who had previously had symptoms consistent with Oropuche virus at about 30 weeks gestation. And then sort of a subsequent investigation, a retrospective investigation, identified 7 infants with microcephaly. And in those individuals, IgM antibodies were identified either in the serum or the CSF from those infants. Overall, the frequency of vertical transmission is poorly understood. It's probably not a surprise given the first case was only identified, several months ago. But this could actually have substantial public health implications. We look at Zika virus, for example. Zika virus is quite similar in that it doesn't cause very serious initial disease. But there were very high rates of vertical transmission and microcephaly, and this really led to a fairly profound and substantial public health impact. Okay, so the what's almost certainly the primary vector, one of what is likely several vectors, but the primary vector, again the Culicoides pariensis, the midge, um, small, down in the bottom right of this, you see this this image on the left, the small the small midge, is sort of shown in comparison to a mosquito. So this is like an actual photo, not a cartoon photo, and just shows you that these are really very small, and that has implications. For example, mosquito bed nets. These midges can penetrate the holes in those, so they don't provide protection. It's just sort of one example. Uh, these these midges feed primarily on humans. Excuse me, primarily on mammals, but that includes humans, but also on amphibians, reptiles, birds, others. And again, this is not really well characterized, the hosts, and almost certainly there's a broader range of hosts. The geographic range of this vector is quite substantial, and you see here on this map. These are countries and states that the vector has been identified in, and really, most of South America, most of Central America, up through Mexico and the southern parts of the United States. So any time that there is a vector active in an area, then there is the potential for transmission via that vector. So this has sort of important implications again when thinking about the possible expansion of the range. Okay, clinical manifestations, clinical features. So it's thought that approximately 60% of individuals who are infected develop symptoms, i.e. about 40% are asymptomatic and don't develop symptoms. Overall symptoms are similar to dengue and a number of other arboviruses, so acute fever, severe headaches, myalgias and arthralgias, which are just muscle aches and joint aches, and there's a range of other clinical features that present photophobia, dizziness, pain behind the eyes, nausea, vomiting, diarrhea, abdominal pain, conjunctival injection, and rash. One quite interesting characteristic of this pathogen is that a relatively large proportion of individuals actually have relapse of symptoms. So it's thought that up to or around 70% of individuals who develop clinical symptoms once due to this pathogen actually have relapse of symptoms subsequently. The pathophysiology of this is really not very well defined and not clarified, but somewhat unusual in that regard. And then the secondary episodes are overall similar to the first episode of illness. And deaths, as mentioned, are rare, but there are a certain proportion that develop either hemorrhagic features, i.e. bleeding, or neurologic features, such as meningitis, meningoencephalitis, and Guillain-Barré syndrome, which is an ascending paralysis. So, sort of the question that always comes up is why now? What was it that happened? What changed so that now this pathogen is being identified in a much larger number of areas and countries than previously, and overall, certainly at this point, this is unclear. There are some thoughts and theories around this, or hypotheses around this. So the effect of deforestation and land use changes. So there have been studies that suggest that the new transmission occurs in areas, particularly areas where there's been deforestation, and this increases or potentially increases the contact between humans and vectors. Increased sequencing capability and improved surveillance. So whenever there is more attention and more testing for a disease or a pathogen, almost certainly you're going to identify more of it. But overall, I think it's highly unlikely that this is the only reason why we're seeing this now. All this certainly could be contributing to some degree. And then genomic mutation or changes to the genomic or the viral genome. There's some certain characteristics of reassortment of the genome in this pathogen that is somewhat unusual, and this certainly could be playing a role. And I'll talk a little bit more about this because there has been some interesting research recently on this topic that is just published. So again, why now is the sort of genetic mutation, reassortment? Is this driving this increase in cases and expansion of the range that we're seeing? This is a paper on the left here. We see a paper that was published just in September of this year, so really just a few weeks ago. In Nature Medicine about the reassortment of Oropuche virus in the Brazilian and the Amazon region. Essentially, these are the viruses. Each virus has three segments, three unique, distinct segments, and these have an ability to reassort in typically a mammal that is infected by two different viruses at the same time. So you have this reassortment, and it's thought that this reassortment can change the fitness and the ability of transmission of the pathogens. So this is actually a really interesting paper. I recommend you take a look. And then this is another manuscript. This is a preprint that is just out again in the last few months that examines sort of a similar question, but in somewhat of a different way. It compares the most common variant or strain that has been identified and compares that to historic strains. So if we look at the top here, I guess the top row, the lighter green, what you see, it's very small, it's hard to see, but essentially the lighter green represents the recent variant or strain that has been circulating, certainly during 2024 and late 2023, and compares that to the wild type or prior strain. And these are cell cultures. These are different types of cell cultures across the top, but it's essentially the same idea. You have the viral titer, and then you have the hours post-infection. So the higher titer just means that there is more virus has grown, so the reproduction is quicker. And what you see that the green line, which is the new strain that has been circulating, just generates a lot more virus. When you have a lot more virus, then it increases the likelihood of transmission. So when you get bitten by a midge and you have a lot of virus in you, and then that midge goes on to bite somebody else, then the likelihood of transmitting the virus is higher. So absolutely has important implications. And then at the bottom here, this is really just looking at the immune escape. I won't go into a lot of detail, but just to say that the recent strain that is circulating has or appears to have a capacity to escape immunity. So individuals that have previously been exposed to Oropuche virus just unable to generate adequate immune response to the new strain when compared to the old strain. So all fairly preliminary data, but certainly is sort of strongly suggestive collectively that there may be some genetic reassortment slash mutation that may be driving what we're seeing. Okay, and uh, essentially, in conclusion, Oropuche is really a neglected emerging pathogen. Has been under-investigated and absolutely has the potential to cause large epidemics in the future and expand beyond the current range. Largely neglected, I think, because it hasn't really impacted the regions of the world and the countries in the world, like the United States, for example, that would sort of drive the large scale research necessary to better characterize this pathogen. Transmission is almost certainly far more widespread than the current data suggests. There's really a lack of testing for this pathogen. And I think if there was more widespread testing, the maps that I showed you previously would look very different. The evidence of the vertical transmission and certainly the microcephaly miscarriage is certainly concerning. Again, as with the prior point, these relatively small number of cases that have been reported are almost certainly a gross underestimate of the actual burden. And so there is the potential for actually some quite substantial public health implications. Although, the caveat is we don't at this point know, but certainly the potential. And then further research is needed, particularly around understanding transmission, right? So understanding the vectors, how effective those vectors are, and understanding the range of hosts. Maybe the top priority should be around candidate vaccinations and moving forward with a vaccination pipeline. Frequency of the vertical transmission. So sort of understanding how often when pregnant women get infected, how often there are complications as a result of that, and whether there are certain time periods during pregnancy that actually it increases or decreases the risk of that vertical transmission. Again, analogous somewhat to Zika virus, and a lot of research was done on this to really characterize this point. And then further research on both the epidemiology in general, but also genomic epidemiology to understand if these preliminary data that we're seeing, if they hold. I think it's always important to sort of verify and validate sort of interesting research findings. So further work around the genomic epidemiology, I really think is a key priority, and understanding if there are changes in the genomic characteristics, if there are also changes in the clinical or phenotypic characteristics, which is another sort of key point, meaning if you get mutation, does this make the disease more severe? Does it make it less severe? Does it have impact on vertical transmission, etc.? So there's a lot that I think still needs to be done. But I advise you to keep your eye on this. I don't think it's going to go away anytime soon. There are a number of other arboviruses that circulated kind of largely below the radar for decades before shifting out of their ecological niche and causing really widespread epidemics and pandemics. So chikungunya is one, and Zika virus for sure is another. West Nile and really no transmission in the Americas. But then in 1999, moved into the Americas and spread very rapidly with quite substantial public health implications. So there are many prior examples of pathogens that's again stay below the radar, but then have really substantial public health implications. So
Thank you so much, Eric. This is terrific, and I have so many questions, and then I see a lot of people posting questions. So I think before I normally take the liberty of asking the first, but I see a lot of hands raised too. So what I'm going to do is I hand it over to Mina first and have her ask her questions. I think she posed 3 questions. Mina, I'm going to turn you on, so you can talk now.
Hi, thank you so much. I had a few questions that I wrote in the chat. The first of which is it suspected that climate change is contributing to increase the midge vector that is spreading this virus? I can list, I have 2 more questions. I can say them all and then you can respond accordingly. The second was, what are the CDC, Harvard, and Central and South American countries and relevant partners doing in addressing the spread? And third, what can people who live in these regions where Oropuche virus is spreading do to avoid getting the virus now? Thank you so much.
yeah, Mina, thanks very much for those important and poignant questions. Yeah. So the first one related to climate change is sort of a key question. I think, frankly, we don't know, but we do know that there is a substantial impact of a number of other arboviruses due to climate change. So I think it is highly likely that the climate change plays some role. Is it primarily climate change that is driving the current expansion in the range and these outbreaks? I don't think we can say because the data is just not there right now. But I would not be surprised at all if that is part of what we are seeing. So that's the first question. The second question, what are the CDC, Harvard, Central America countries doing? So the CDC have set up sort of an emergency response team. They are sending CDC staff to South America, to the Caribbean. I know of several that are in the Dominican Republic to work with the countries to better characterize the data that they have and then build out the testing abilities, supporting the countries mostly with the PCR testing. And I know the PAHO is also doing the same thing. So, I think a lot of those activities are sort of overlapping between WHO/PAHO and the CDC. What is Harvard doing? I don't think that there's any, as far as I know, there's no specific activities. From my side, we, as I mentioned, we did a lot of work. We have done a lot of work in the Dominican Republic, including a national serological survey. It enrolled about 7,000 individuals from all over the country, and we have a lot of samples from that. And so I'm in discussion with the CDC and with the Dominican Republic about testing those samples for evidence of antibodies. This wouldn't help sort of the immediate response, but what it would do is it would help us better understand, is what we're seeing new, or actually has there been ongoing transmission? And in this case, specifically in the Dominican Republic, but I think the same question can be asked in many other settings. And so we're in discussions about that now, about the testing for that. It takes some time and some resources to test 7,000 samples. And we have other samples that they're looking to test, but I won't get into all those details right now. So and then the third question is around what those who live in regions where Oropuche virus is spreading, how do they avoid getting the virus? So there's a few, yeah, a fantastic question. In fact, I actually included one slide. I wasn't sure on the timing. It looks like we have plenty of time, but I included a slide just summarizing sort of the control measures. So maybe I'll just like skip onto that, and then that should be able to sort of summarize it. So this is so part of it is in general the public health response, typically driven by the Ministry of Health, and the other is individual level things that people can do, which I guess is more your question, but sort of expanding even beyond that question more broadly as to what can be done. So so it falls into sort of 4 general buckets or categories. So vector control, so specifically around midge control. There, it's not so easy. It's not the vector control for midges is not as well defined as it is for many of the sort of key mosquito species. But applying insecticide, larviciding stagnant water, and then environmental management. As mentioned here, clearing vegetation around human settlements, etc. As far as on the personal level, use of insecticides, insect repellents, and then sort of the standard similar recommendations that you would use for prevention of dengue. So insecticide treated clothing. We mentioned bed nets here. I'm not so convinced. Insecticide treated bed nets, maybe they would work, but bed nets in general, the holes in them are and the midge is so small they can actually get through the holes typically. And then air conditioning and window screens are sort of critical. Surveillance, early detection, so ensuring that there's vector surveillance programs to understand midge populations, strengthening epidemiologic surveillance, particularly around ensuring that the testing is available. If there's no, these pathogens clinically overlap so much. When I say these pathogens, I mean like chikungunya and Zika and Oropuche and dengue. So clinically, it's almost impossible to tell these pathogens apart. So you really need testing, PCR testing to be able to do that. And then serological surveys can kind of characterize the transmission of the pathogens in the country. And then health awareness, public health awareness campaigns, engaging the communities, etc. So I think that was the 3 questions. So back to you, Fang.
Yeah, thank you so much, Eric. And if you have any questions, please feel free to raise your hand. I think, if not, I do have a few questions for you. One is related to your last point about testing. Do the governments right now do they have the capacity in Latin America and in the US to test this at a large scale to distinguish between the different vectors? Um, and then I think the second questions, which is just a curiosity, you mentioned that 70% of the patients so far has relapse, and that some of this that there's escape immunity. I'm just wondering, do you think that internally there's genetic reassortment within the body to cause that relapse, or can a body get rid of the viruses? There's something that is curious about our immune system, right? If we have relapse, that means we're not getting rid of the virus, like some strain of it standing behind, even though we don't have symptoms again to have that relapse. So just curious about that as well.
Yeah, that's a good question. So in general, the reassortment occurs when there are 2 different viral strains in typically in a mammal at the same time, and that's when you're getting the shifting of the gene segments. It would be unusual for that to happen frequently. That's something that would happen, you would expect to happen relatively rarely, that the same mammal would have two different viruses. So I don't think that is driving this recurrence or sort of resurgence of symptoms. And frankly, I have not seen any good explanation for why this occurs. So I'm just not sure. There could be a role of immunity in this. So like COVID, for example, you have your acute symptoms, and then when people used to, not so much anymore, but when people used to get really sick, it was actually a week or so later. It was the immune inflammatory phase, when there's actually no virus left. It's just the immune system causing these symptoms. So there could be a role in that, but again, it just hasn't really been clarified or delineated very clearly. As far as your first question and about whether the countries in the regions have the capacity to do the testing. So some countries have pretty sophisticated surveillance, including laboratory surveillance, particularly Brazil. But many do not, and many are not typically testing. So in order to roll this out sort of on a large scale, ideally you would develop a multiplex test where you can test for multiple pathogens at the same time. So you could have a combined dengue Oropuche PCR test, for example. I mean, ideally you have it for multiple pathogens, but that also then starts making it very expensive. The CDC and PAHO/WHO are supporting countries with developing or implementing the PCR testing necessary for Oropuche. But this is a big job, and almost certainly these countries are not going to have the capacity to roll out this testing for large numbers of samples coming in. So it'll be sort of select samples that they sort of randomly select to identify whether or not there's a lot of transmission. But to get to the point where you're testing, a large number of individuals who present with this type of undifferentiated fever, I think that takes time and a lot of resources.
You also mentioned there's been several cases in the US. What about our capacity to test them? Can people, go and get tested easily in the US? And is that a concern here in the US? I see that it's most of the cases are in Florida, right?
Yeah, no, that's a excellent question. So typically this type of testing would be considered like reference lab testing. So this is something they would do at the state labs, for example, or probably select state labs. I am not sure if all state labs would have this. If there was the high suspicion, then the CDC and the individual meets certain criteria, then the samples can be sent to the CDC, and the CDC will do the testing. But the turnaround is not fast, but that's sort of the ultimate reference testing is the arboviral branch in Fort Collins for the CDC.
And then another question is about midge control. It seems like if we can do midge control well, just even to counter like malaria and some of the other type of similar um, uh, vector, you think that will take care of this? Would that you have, will take care of this or approach problems, or you think we need something that's more specific to this?
Yeah, that's a good question. So vector control can be very sensitive. So probably the most effective approach is spraying. And for anybody who's around during West Nile, they'll remember that this became politically quite fraught. So people want to reduce the risk, but they don't want insecticide widespread spraying throughout their communities. So there are approaches that likely would help to suppress midge population. They have also a knock-on ecological impact, and they can be challenging as far as the sort of the resistance from the communities. Which I mean, I understand these concerns that are raised.
Okay. And Maple, I see you have a questions here too, so you're welcome to unmute yourself.
Oh, hey, Eric. I just wondered that you kind of answered this already, but what measures are being taken at the moment to improve and expand the diagnostic capabilities for the virus, particularly in like newly affected areas? It sounds like there's quite a lot of disparity between diagnostic capabilities and surveillance capabilities across the countries.
Yeah, absolutely. I mean, I think there's huge disparities. Uh, Primarily for countries that really have sort of limited financial resources, it's essentially relying on PAHO/WHO and or the CDC. Public health is always a question of priorities, and there are always many competing priorities. And the question is, for a country, do they want to direct their limited public health resources, invest them into setting up and continuing to support this type of surveillance? And I think, frankly, for a lot of countries, at this point, that would probably not be the case. I'm sure that there was a lot of enthusiasm for the testing, but again, really hard decisions are made about what to prioritize. And so I think countries in that situation typically will rely on PAHO and or the CDC to support this, particularly when there are high levels of concern about the increase in the outbreaks, the increase in the range, and concerns around the issues like vertical transmission and the public health consequences. So the more concern there is around the pathogen, the more easy it is to access resources. But overall, your point is absolutely right that there's substantial disparities across the region.
Thank you.
And Eric, you mentioned earlier that there's no vaccines for this. Are there people working on vaccines on this? And yeah, so I'll just let you answer that question first, and then I'll follow up with another question.
So there's certainly no vaccines in advanced stage of development and testing. It seems like there are some candidate vaccines very early in the pipeline. There are also some veterinary vaccines for pathogens that are very closely related to Oropuche that are thought not that those vaccines would be used in humans, but actually understanding the approach for the development of the vaccine, etc., actually could be leveraged to fast track a vaccine development. But that's about as far as I know on that. Yeah, so certainly nothing in advanced stages at this point.
Well, thank you so much for that. And I think we are heading toward the end of the hours, but I just want to thank you so much for taking the time to discuss and educate us about this new emerging virus, and very neglected too, because truthfully, I haven't heard about it until you mentioned it. And so I think this is I think one for a lot of our students to watch, and then also really ripe for a lot of research. So I don't know if you want to have any closing recommendations for students, but you outlined quite a few areas of topics for students. But anything you want to say before we head up? But I just want to say thank you for spending this hour with us.
Yeah, I mean, I think there's a lot of research that needs to be done. There's not at this point, I think, the sort of like for other pathogens, there's large data sets that can be explored as sort of perfect student projects. At this point, I think a lot of the work is still being set up. But if there's anyone who really has an interest in this or similar topics and would like to talk about potential research projects, then definitely, reach out to me. Be very happy to chat about that.
Thank you so much. And thank you for that open invitations to our students. So have a good day and have a good weekend, everyone. Thank you
Great.
for joining us today.
Thanks very much.